Okay, let's unpack this. We're diving into one of the world's most analyzed and certainly most argued over public institutions, the UK's National Health Service.
It's a huge topic.
A huge topic.
Right.
And for this deep dive, we've been handed a document that feels less like a reform proposal and more like a detailed 30-year engineering blueprint.
Right. It's about achieving structural stability.
Exactly. So our mission today is to cut through the noise, figure out why, after 75 years, the system has failed to stabilize, and uncover what radical yet surprisingly foundational changes are being proposed to finally fix it.
And the central thesis presented in these sources is, well, it's pretty stark. If you look at high-performing health systems globally, we're talking France, Denmark, Sweden, the Netherlands.
The usual suspects.
The usual suspects, yes. They all rely on a predictable, stable foundation. The argument here is that for 75 years, the NHS has simply never been given that.
And here's where it gets really interesting and frankly a bit counterintuitive. The central argument isn't that the NHS hasn't changed enough.
No, quite the opposite.
It's that it has changed too much, often pointlessly. And the resulting chaos is, well, it's self-inflicted.
The source quotes that old Roman saying, the only constant is change. But in the context of the NHS, change has become a complete substitute for actual improvement.
So every new government comes in, decides they need to put their stamp on it.
And tears down the administrative architecture that the previous government just finished building.
It suggests that if we want the NHS to thrive over the next 3 decades, we need to stop treating it like a political football.
Exactly. Stop with the short-term reorganization.
And start designing a system that is actually built to last.
We need engineering, not perpetual chaos.
When you look at the history of this,
Yeah.
this organizational churn in England alone, that call to stop reorganizing feels incredibly urgent.
It's more than urgent. We're talking about administrative chaos that rivals the speed of tech evolution, but, without any of the benefits.
Right.
The list of administrative acronyms we've generated over the last few decades is frankly bewildering.
I can imagine.
The source walks us through the cycle, and you really do need a flow chart. We've had 14 regional health authorities, then 95 health authorities, then 152 primary care trusts, followed by 10 strategic health authorities.
And it doesn't stop there.
Not at all. That was followed by 211 clinical commissioning groups. Remember those?
Vaguely.
And now we currently sit at 42 integrated care systems, or ICSs.
That volatility is exhausting just to read aloud. I mean, has any other country had this many versions of its core health governance structure in just 3 decades?
It seems like a recipe for institutional amnesia.
It is, and the volatility is completely unnecessary when you compare it to our international peers.
The high-performing ones.
Exactly, the systems that actually deliver excellent care. Their reforms were slow, predictable, and purposeful, often taking a decade or more to just implement and test.
France operates with 17 regions for health planning. Denmark manages its entire healthcare system through just 5 regions.
And Denmark's population is about the size of Scotland's, right?
Roughly, yes. And Sweden has 21. They reformed slowly. England, on the other hand, reforms dramatically, repeatedly, and then immediately prepares to undo the last reorganization.
So the first key proposal for achieving stability is simply forcing the system to adopt a governance structure that remains in place for 20 to 30 years.
A full generation.
A full generation. That's the stability goal. The question is, what does that new, long-lasting structure look like?
It starts with the absolute simplification of all the management layers.
And the blueprint focuses on this first pillar, a clear, simple regional structure, specifically the creation of around 30 to 35 regional care authorities, or RCAs.
This is about replacing the fragmented mess of ICSs and all the previous structures with a decisive, regionally focused body that actually has teeth.
Okay, 30 to 35 RCAs sounds manageable, but we've seen regional bodies before, and they've just become another layer of bureaucracy. What makes this proposal different?
That is precisely the challenge, isn't it?
Isn't there a risk that these huge regional bodies just become their own slow-moving, untouchable bureaucracies?
Well, the blueprint addresses that by defining their role very clearly and by insulating them politically. The RCAs would be powerful entities designed to integrate and control resources across a specific population.
They have real power.
Real power. Their powers would include controlling all hospital budgets in their area, integrating primary, community, mental health, and social care. They would be the single planning and funding body for their region.
But what about that political interference?
That's the critical element for stability. The blueprint emphasizes that the structure of these RCAs should be politically insulated from ministerial whims.
So hard to abolish.
Very difficult to abolish. This mirrors the successful models in France, Denmark, and Sweden, where regional bodies are autonomous and not subject to, annual interference from central government.
So stability is the architecture.
Yeah.
But the blueprint also stresses that stability needs a prerequisite, one national service standard. What exactly does that mean for patients?
It means clarity across the board. If we stop reorganizing, we need to agree on what the NHS actually promises.
So clear entitlements.
Clear entitlements for patients, what you should expect to receive. Clear performance expectations for providers, and crucially, clear accountability for outcomes. It's about building a stable platform based on common expectations.
Instead of constantly shifting administrative boundaries and local variations.
Exactly.
That brings us neatly to the second major issue, the source tackles, the core operational model. We have to talk about ending the purchaser-provider split.
Ah, yes, the internal market.
For listeners who might not be steeped in NHS jargon, can you just quickly explain what that split is and why it was even introduced in the first place?
Of course. Essentially, the purchaser-provider split was an attempt to inject competition into the public system. The purchasers, like those clinical commissioning groups we mentioned, would commission or buy services for their local population.
And the hospitals, the providers, would compete to sell those services.
In theory, yes.
And the source is clear. Competition has failed, arguing that the internal market is fundamentally a market fiction. Why?
Because markets require two things: mobility and choice. In healthcare, you just don't have that.
Right.
If you are brought into A&E with a stroke or severe trauma, you don't have a choice. The market constraints are structurally impossible for the vast majority of acute NHS services, like cancer treatment or maternity care.
So this market fiction ended up creating perverse incentives instead of efficiency.
Exactly. Hospitals ended up prioritizing billable activity over integrated care. They competed for patients who were easy to treat and, sometimes avoided patients who required complex, coordinated care.
Which directly undermined the core purpose of a national health service.
Precisely. It created fragmentation.
So if we abolish this internal contracting, these billing flows, what replaces it in this new, stable system?
The model shifts entirely to planning plus accountability. Instead of market signals, the new RCAs would become the planners. They'd be funded based on weighted population need.
Meaning if their population is older or has more complex health needs, they get more money.
That's it. And crucially, providers, the hospitals and so on, would be funded directly through stable multi-year budgets. You stop forcing hospitals to spend time invoicing each other for every little service.
That seems like a massive reduction in administrative overhead right there.
It is. This restores the logic of planning services around genuine population needs rather than theoretical market forces. Accountability then comes from transparent metrics and outcomes.
Measured against that new national service standard we talked about.
Exactly.
Now onto the third crucial pillar, which is primary care. The blueprint describes integrating it as a sort of reverse Bevan's compromise. We need to pause on that because that's deep history.
It is. The original Bevan's Compromise in 1948 was the political deal that brought the NHS into being. Hospitals were nationalized, but general practitioners, GPs, remained independent contractors.
It was a deal to get them on board.
Yes, it ensured the GPs joined the system, but maintained their clinical freedom and, importantly, their business autonomy.
So a reverse compromise suggests keeping that clinical autonomy, which is crucial, but ending the business model instability and the fragmentation of the system.
Precisely. The goal is to bring GP practices into regional NHS networks as contracted professionals, integrating them deeply into the care teams while retaining their essential clinical independence.
How do you achieve that structurally? Because right now, many practices are tiny, struggling businesses.
The major step here is consolidating those practices into larger primary care groups, or PCGs. This follows successful models in New Zealand, the Netherlands, and Denmark.
And larger groups mean more resilience.
Better resilience, shared administrative burdens, access to diagnostics, and the capacity for truly team-based care like having pharmacists and mental health workers operating seamlessly together. Plus, they can offer extended hours more easily.
And this consolidation directly addresses a massive issue patients face, the business risk of the small practice. If your local GP retires, the whole practice can just collapse.
The blueprint is emphatic on this point. Patient care should never suffer because of the commercial viability or failure of a small GP partnership. This consolidation ends that vulnerability.
Now, let's shift to the critical question that brings this all together. Money. For decades, we hear the NHS is chronically starved of funding. If that's the case, why hasn't it been fixed? The blueprint provides a stunning financial analysis here.
Yeah, it really does.
Let's start with the investment that is actually needed to stabilize the ship.
Okay. The sources make it very clear that structural reform alone is not enough. To simply stop the multi-generational decline, a one-off minimum capital investment of 22 to 27 billion pounds over 5 years is required.
And that's the minimum, not the budget for Nordic luxury, as they put it.
Not at all. This is just to drag the NHS infrastructure into the 21st century. It breaks down into non-negotiable areas. 10 to 12 billion pounds to clear the hospital capital backlog.
Crumbling hospitals.
Yes. 5 to 7 billion pounds for a desperately needed digital infrastructure upgrade, and another 3 to 4 billion pounds for primary care expansion and modernization.
Okay, 27 billion is a huge number. But hold that thought, because here is the aha moment that makes you stop and reread the sources. It ties back to what we said at the beginning about perpetual reform.
The true cost of the chaos.
Yes. The staggering figure for money wasted on administrative churn is estimated to be between £50 and 70 billion.
Wait, 50 to 70 billion.
50 to 70, that number is just stunning.
It is a colossal, mind-boggling sum, and that's money that did not go into patient care, new scanners, or nurse salaries. It went into sustaining the cycle of administrative churn.
Dismantling systems and rebuilding them under new names every 5 years. Can you detail exactly where that money went? Because this is crucial. It went to the professional services industry.
It did. We're talking about massive fees paid to management consultancies, the McKinseys, the KPMGs, the Deloittes, and PwCs, hired for constant restructuring and endless turnaround programs.
Every time the government changed direction.
Every single time. It also went to accountancy firms to create new financial frameworks, audit the endless cycles of trust mergers, and redesign billing systems that were about to be abolished anyway.
And then there's the cost of the internal management instability itself.
Precisely. It went to interim managers, often paid at eye-watering rates of 800 to 1,600 pounds per day, simply to stabilize organizations that had been intentionally destabilized by the reforms.
And redundancies.
Absolutely. The upheaval following the 2012 reforms alone cost the taxpayers $600 million in redundancy payments, and many of those people were often rehired into equivalent roles shortly after.
So the financial synthesis is absolutely devastating.
Right.
The NHS didn't lie to money. The money was there, but it was consumed by the process of perpetual reform.
It was burned by the engine of reform.
Avoiding that cycle could have afforded the required $22 to $27 billion investment to modernize the system. Not just once.
But twice over. That's the core realization. The cost of instability is double the cost of long-term modernization. The beneficiaries were administrative industries, not patients.
The most expensive thing the NHS has ever done is try to save money through endless reorganization.
It's a profound irony.
Let's move to the final two systemic changes required. The first involves prevention. It has to move from being a mere slogan and speeches to a fundamental system logic.
Right. Currently, the UK spends among the lowest in the OECD on prevention, which the source correctly identifies as costly and irrational. We pay for the ambulance at the bottom of the cliff rather than fencing the cliff top.
So how does the new stable structure fix this?
Yeah.
Every health minister talks about prevention, but the money never follows.
The RCAs would be given a clear mandate and specific funding streams to embed prevention. It means shifting spending upstream.
Like community nursing.
Early diagnostics. Exactly. And crucially, the blueprint suggests linking financial incentives for the RCAs to long-term health outcomes, like reducing local obesity rates over a 5-year window, rather than just reacting to short-term hospital bed pressures.
That structural link, the financial incentive tied to outcomes, seems key to making it stick.
It is. It forces the regional care authority to think 20 years down the line, not 20 days.
And the final, and perhaps most ambitious pillar, goes beyond health policy and into constitutional engineering, ending the political pendulum.
This is a big one.
The NHS, they argue, cannot be structurally stable on an unstable constitutional foundation.
This is where we need to connect the dots back to the source of the churn. Under the current first-past-the-post electoral system, a party can win with 40% of the vote and immediately enact sweeping changes to the NHS.
Often just for ministerial branding.
Yes, or to please a core constituency. Churn becomes structural because the incoming party has no incentive to maintain a predecessor's reforms.
So the very system of government makes the NHS inherently unstable.
Exactly. And you contrast this with the models they point to. proportional democracies like Denmark, Sweden, and the Netherlands, these systems inherently require consensus.
Through coalition governments, usually.
Yes, to enact major system-wide reforms. This necessity for cross-party consensus results in stable health architecture that avoids these radical oscillations.
So the source suggests that a constitutional guarantee, or at least a powerful legislative mechanism, is necessary to ensure the NHS cannot be restructured at ministerial whim.
That consistency is the only way to deliver the 30-year engineering stability they seek.
So let's bring this all back to you, the listener. The core message of this blueprint is surprisingly simple. The NHS doesn't need more dramatic reform. It needs long-term engineering and unwavering consistency across 5 areas.
A politically protected governance structure via RCAs.
Integrated care pathways replacing the expensive market fiction.
Massive, targeted capital investment to modernize.
Robust and resilient primary care groups.
And finally, political protection from short-term branding.
The financial revelation is what stands out most strongly, and it raises an important question for you to explore as you consider this blueprint.
Given the documented fact that avoiding the last 3 decades of structural churn could have funded system modernization twice over, what fundamental incentives currently drive decision-makers to repeatedly prioritize management consultancies and short-term reorganization over the long-term stability and patient care that the public desperately needs? And how does that same dynamic play out in the context of other public services you rely on?